Second white coat. Subscribe and like. Let's learn medicine together.
Welcome to this explainer. Today, we are stepping into the shoes of a clinical detective to solve a classic high-yield kidney vignette. You know that feeling when you're staring at a massive wall of exam text and just feel totally overwhelmed by all the scattered clues? Well, you're in the right place. We're going to learn exactly how to organize that raw data, branch your differential diagnoses, and absolutely nail the right answer.
Okay, so here's our raw crime scene. We've got a 12-year-old boy who's brought into the clinic because of facial puffiness. On exam, he has periorbital edema. Then we get to his urinalysis. It shows 1+ protein, a trace of blood, 3 to 5 white blood cells, 20 to 30 red blood cells, and, this is the crucial part, red blood cell casts, no crystals. The question we need to answer is, which of the following additional findings is most likely to be present in this patient? But before we even look at the choices, let's build our strategy.
To crack this case, we'll use a foolproof 6-step roadmap: decoding the question stem, defining the syndrome, visualizing the pathology, the complement pathway trap, eliminating wrong answers, and finally, exam day shortcuts. Let's jump right in. Step 1. Decoding the question stem. This is where we translate those raw clues into clinical language. We really have to shift our thinking from a layperson into a master diagnostician. When we read facial puffiness, we don't just stop there. We automatically translate that to fluid retention from kidney inflammation. Trace blood? That becomes glomerular bleeding. And that massive standout clue, RBC casts, instantly translates to nephritic syndrome. By actively translating as you read, you instantly organize all that chaos into recognizable medical patterns.
Step 2. Defining the syndrome. This is your foundational anchor. Listen, this is basically the golden rule of renal medicine. The very moment you see the words RBC casts, your brain needs to immediately fire off glomerulonephritis, which equals nephritic syndrome. What's happening is the red blood cells are squeezing through a highly inflamed glomerulus, and they literally take the shape of the tubules as they exit. Establishing nephritic syndrome right off the bat instantly eliminates half of all renal diseases from your suspect list.
Step 3. Visualizing the pathology to identify our prime suspect. So we have a child with nephritic syndrome. The prime suspect? Poststreptococcal Glomerulonephritis, or PSGN. And we have the physical evidence right here. Looking at a raw biopsy mugshot of this disease, you can clearly see this overwhelming, dense cluster of cells just packing the space. But how did this crime actually happen?
What's going on under the hood in PSGNN is basically a 5-step chain reaction. 1. The patient has a prior group A strep infection. 2. The immune system forms immune complexes. 3. Those complexes deposit straight into the glomerulus. 4. They trigger complement activation. And 5. That causes massive inflammation, resulting in the nephritic syndrome we're seeing in our 12-year-old patient.
When you look at an annotated biopsy under light microscopy, PSGN presents exactly like this: a dramatically enlarged, hypercellular glomerulus. It is visibly swollen with a huge leukocyte infiltration, along with endothelial and mesangial proliferation. All of this is a direct reaction to those deposited immune complexes. Now, to really lock in that PSGN diagnosis, you want to look for corroborating evidence. On immunofluorescence, you're looking for granular deposits of IgG and C3. This creates that classic starry sky appearance. If you zoom way in with electron microscopy, you'll see subepithelial humps. And in the patient's blood work, expect to find an elevated ASO titer, which points to prior strep throat, or elevated anti-DNase B, which points to prior impetigo.
Step 4. The complement pathway trap. This is really the core difficulty of this entire question.
All right, here is the smoking gun. When those immune complexes trigger the complement system in PSGN, they specifically activate the alternative complement pathway. Think of this alternative pathway like a highly selective Pac-Man. It burns right through C3, just eating it all up, but it completely ignores C4. Because of that, your expected lab findings are going to be a significantly decreased C3 level alongside a totally normal C4. Understanding that selective consumption is the key that unlocks the right answer.
Step 5. Eliminating wrong answers. Time to methodically interrogate the lineup.
Let's go through these options one by one. Choice A, Goodpasture syndrome. That requires hemoptysis and crescents on the biopsy. We don't have those, so it's out. Choice B, ANCA vasculitis, exceedingly rare in children. Out. Choice D, decreased C4. Well, that implies a classical pathway disease like lupus, but remember our trap, PSGN lowers C3, not C4. So that's out. And choice E,
Eosinophils. That points to acute interstitial nephritis, which requires a fever and a specific drug history, neither of which are in our stem. By elimination and our own positive confirmation, our culprit is absolutely a decreased serum C3 level.
Finally, Step 6, Exam Day Shortcuts. Let's synthesize all these takeaways.
Here is your ultimate exam day reflex equation. Child plus periorbital edema plus RBC casts equals nephritic syndrome, and most likely PSGN. The exact second you think PSGN, your brain should automatically populate the expected labs: decreased C3, normal C4, and an elevated ASO. We decoded the clues, we visualized that hypercellular glomerulus, and we totally navigated the complement trap to confidently arrive at decreased C3.
You know, diagnostic medicine isn't just about memorizing random lists of facts. It's about chaining together clues into unshakable, logical pathways. So, the next time you see the phrase RBC casts on a vignette, what clinical reasoning pathway will your brain activate? Thank you so much for joining me on this explainer. Keep practicing those deductive pathways, and I'll see you next time.